Very good evening, all doctors. I am Pankaj Sahu, working as a business development manager at Emcure. Today, it's our immense pleasure for this 3B webinar. This is the first kind of a webinar which has been taken, which is going to be taken care for the all health-related issues in gynecological era. So today I would like to invite Dr. Kalyani Srimali from Indore to start this session. Dr. Srimali.
Yeah, thank you, Mr. Pankaj, and thank you, Emcure, at the outset that you have landed us this platform to start with our webinar series for today. So I welcome all our esteemed guests and all our panelists for today's webinar series. As the name suggests, this is the 3B. Our 3B from Indore, Dr. Kavita Bapat ma'am, Dr. Asha Bakshi ma'am, and Dr. Archana Baser ma'am. So this is their creation where we are starting with the common gynecological problem. We just want every person who is logging in to just learn the simple basic things about gynecology, some small questions or some queries or whatever, whatever we are dealing in our practical life. So let's start with today's webinar. So today's episode is on endometriosis, the common questions, what we need to know about the endometriosis. So I would like to start first by introducing, can we have the PowerPoint, Mr. Pankaj, or should I share?
I'm sharing.
Okay.
Kalyani, your video is also not there.
Okay. Okay, so let's just start the slideshow.
I hope, ma'am, it is visible to you.
Yes. So nextly, so I would like to introduce and welcome Dr. Asha Bakshi ma'am for today's event. We all know Dr. Bakshi, she needs no introduction. She is the lead consultant for Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital. She is also the Vice President-elect 2022 for West Zone FOXI and Treasurer ISA 2021. Member executive for various committees. Ma'am needs no introduction. She has won multiple awards, multiple authorized chapters, and written so many articles in various national and international journals. She has been the coordinator and the organizing person for so many conferences, including our FOXI, the AICOG, what we had here. Ma'am, I like to welcome you for today's webinar. And I would like you to introduce Dr. Suchitra ma'am as the guest of honor. Ma'am, the dais belongs to you, Bakshi ma'am.
CV for Dr. Suchitra. It's indeed an honor to introduce Dr. Suchitra, who is a close friend and a very learned, very gentle and a very noble person. About her academics, she's MD, DNB, FRCOG, FICOG, TFP, MNAMS and all that. And she's teacher of teachers, that much I can say. She has been a senior, she's at the moment, she's a senior consultant in Surya Group of Hospitals in Mumbai. And she has been chairperson AICC, RCOG, President ISOPAR, President Justosis India, President FOXI and ICOG, and President Mumbai Obs and Gynae Society, Professor and Unit Chief at LTMMC, LTMG Hospital, Sion, has been a PG teacher for 34 years and has conducted many research projects and has been examiner for so many undergraduate and postgraduate exams. She has initiated the FOXI Justosis course, which is a very well attended course. Then he has conceptualized FOXI Youth Mela, and I still remember how youth is close to her, and she is all the time talking about youth. She is a voice for youth, so that is how Suchitra is. She has participated in good clinical practice guidelines. Then and continuing work of DCPR. She has been secretary FOXI, then a member of APAC committee, Lord Planets Awards and many other awards. I remember that she received a FIGO Women's Award in 2018, and we have witnessed that. And she has received many national as well as international awards. and she has been awarded 40 orations, more than 2,500 guest lectures in India as well as abroad. And she has many publications to her credit, and she has a lovely voice. When she speaks, you feel she's somebody, some nightingale is shouting. So this is Suchitra, and I welcome you, Suchitra, to this 3B platform. And it's so nice to have you here.
Thank you very much, Asha.
We would like to call upon Dr. Basse ma'am. Basse ma'am, would you introduce Dr. Kavita Bapat ma'am so that we can take this dialogue forward? Mr. Pankaj, please change the slide.
Hi, good evening, everyone. Again, welcome to 3B platform. And
I think I don't need introduction in the 3B.
No. Just one line introduction, Dr. Kavita Bapat, not much introduction. Dr. Kavita Bapat, she is a very famous person. She connects very well with everyone, especially the Foxian. She has been Vice President Foxy 21-22. She's a very dear friend. She is a good academician, and most of all, she is a down-to-earth person and very approachable, methodical, and she is hardworking person. So I, on the dais, I invite Dr. Kavita Bapat to have dialogue with Dr. Suchitra Pandit. She's our guest of honor as well, Dr. Suchitra, and she has kindly agreed to, have a good conversation with Dr. Kavita Bapat. So Kavita, over to you.
Thank you so much.
One more thing I would like to say for Kavita is that she speaks for the cause. She's not scared of anybody and not hesitant. And whenever there is a problem, she's ready to speak out. So that is a very good quality of leadership.
Love you.
So,
and helps everyone out. Maybe it's the local or it's national. She's always there. And Bapat ma'am, I really love the last part, the avid dog lover, the passionate safari, the coolest grandmother, and the person with faith. That's amazing.
Thank you so much. I'm so blessed to have my Indoris are standing with me. So Suchitra Pandit, good morning, good afternoon, everyone. And I'm really blessed to do this program, really happy. First of all, I'd like to tell that Suchitra Pandit is a person with a par excellence. As Dr. Asha Bakshi has said, she has a remarkable contribution as a leader, as a mentor, as a president of various things. But now she is at present is a president of Justosis or the world. This is a world body, and she's president of the Justosis. Exceptional singer, as everybody talked about, and exemplary and a dedication in her world. What the way that she works. Overall, an outstanding individual, talented, expertise, leadership. My mentor. I always say she is the person who took me from Indore to take on the stage. Love you for this. We have traveled together, me, Dr. Bakshi and Dr. Suchitra Pandit together, and we had a real fun all the time. And the best part, her dedication and commitment is really commendable. And she serves as a shining example to others to follow. So Suchitra madam, welcome to this stage. We'll have just few questions, and this will be a take-home message for many. And we are going to talk, as being you are a Justosis president. So we'll love to talk about something which is hypertensive, though the subject today is not of the hypertension, it's endometriosis, but still we'll love to talk about the few questions about the hypertension. It's very important topic. So the first question to you, what are the hypertensive diseases or we are talking about? And what are the changes of definition which we are seeing nowadays? See, hypertension and in a pregnancy is a big topic, very threatenful. It is one of the reasons for the maternal mortality. So over to you. And the question is, I think I'm not repeating it. The question is the definition and what are the diseases which we
Thank you very much, first of all, Kavita, for inviting me for this particular session. And I'm glad that, this is a topic which we are discussing. I know endometriosis is also important, but this is something when we're talking of maternal mortality. Hypertensive disorders in pregnancy are the contributor to a very high percentage of maternal as well as perinatal morbidity and mortality. In fact, it's second to PPH. So when you're talking about what it comprises, obviously, whenever there is a rise of blood pressure, systolic to 140 and diastolic to 90, that is taken as blood pressure in pregnancy. And what does it comprise of? Obviously, preeclampsia, eclampsia, gestational hypertension, and we are talking of the chronic hypertension. And if you're looking at the percentage, almost 8 to 10% of our OPD patients have hypertension in pregnancy. And out of this, around 1.5 to 2% still go in for eclampsia. And this is the national, as per the National Eclampsia Registry. Now, when we're talking of definitions, I'd like to bring out two important things in this. One is that the time when we start treating is 140/90. Earlier times, people used to take 150/100, but now the ISSHP and the World Organization Dystosis have agreed that the BP that would be important is 140/90. Of course, you take it on 2 occasions. Sometimes the patient is very tensed up, or she's climbed upstairs, or she's chewed tobacco, so you may get a wrong reading. So please repeat that blood pressure after 20 to 25 minutes. And if you still find that the BP is coming 140/90, that is the time to start treating. The second most important thing is, we used to talk of mild, moderate, severe. Now it is severe. So non-severe includes mild to moderate, and severe is when the BP is 160, 110 and above, and all the severe problems that are accompanied with it. And non-severe is anything 140/90 to 159/109. That would be taken as the now proteinuria is no longer taken as a must for defining preeclampsia, because when you're talking of preeclampsia, it's the onset of hypertension after 20 weeks. We used to always say proteinuria, but now proteinuria is not necessary, because the multi-organ problems are seen even before the proteinuria has started. So that is another change which is coming. And the most important thing is, today when we're talking of how has that changed, the management therefore changes depending on what category the patient belongs to. And we have this new entity of atypical preeclampsia, which defines none of the definitions, meaning it just comes on as a surprise. So we are learning more and more of this particular entity, Kavita.
Correct. Amazing. So you mean that we are worried at the 140/90, we are not too worried about the proteinuria, and
Yes.
atypical preeclampsia is another big thing. It's a really good thing. So are the screening modalities are adequate for the new tests? Are there anything in the country which we talk about, anything we have to do for the sonography, as we are already having? Dr. Kuldeep Singh is also with us, but the dialogue is between you and me. If we'll need, we'll take him in. But what I think any modalities, screening modalities are there in our country for this, how to access the sonography?
Now, basically HDP, we call it hypertensive disorders of pregnancy, is such an enigmatic condition, and it has got such varied clinical presentations and so many phenotypes that there is no single test which fits the bill. You know, WHO's test always, screen test always says it should be simple, easy, inexpensive, reliable, and replicable. Now, the tests which were there earlier, you know, simple OPD tests are taking the weight, taking the BP of the patient, taking the history of the patient, previous history of preeclampsia, we used to put in a tick mark. But what we find today, you know, there are fancy tests. Of course, ultrasound is there. Wherever access is there, you have this wonderful aspirate trial, which has shown us that you can do all, you know, the basic maternal markers, including mean arterial pressure. And along with that, you do the nuchal scan and you do the dual marker. But along with the dual marker, you're also not just doing PAPE, but you're also doing the PLGF, so that the moms of these can be calculated. And they have found that wherever there is a positive test, the patient who is having this test should be given 150 milligrams of aspirin, low dose aspirin it's called, and then it reduces the incidence of preterm preeclampsia by nearly 60%. There is a false positive rate of 10% of year. But remember, the aspirate trial is a hi-fi screening test. I say hi-fi because it's available to the metropolitan cities and not in every medical college. Again, when you got the combination of biophysical and biochemical markers, they are wonderful. There is so much of work going on in that. But currently, we are not, you know, we can't reproduce them everywhere. So what fits the bill is what we have devised through the Dystosis India Association, the Dystosis score. Dystosis score has got 27 maternal characteristics. We label it as mild, moderate, and severe. Mild is easy to remember. It gets a score of 1, where mild, you're talking about the age of the patient, the weight of the patient, the BM, history of PCOS.
Yeah.
And today, history of ART with ICSI is given as a grade 1. And along with that, if this family history of dyslipidemia, but the moment the patient has a history of familial history of preeclampsia, the mother has had it, sister has it, that goes to grade 2. Pre-gestational diabetes goes to grade 2, or a history of chronic hypertension goes to grade 2. And in the severe, you have got anyone who's got inherited or acquired thrombophilia, or pre-existing diabetes mellitus, or a chronic kidney disease. And very important, Kavita, today, ART, when you're talking of egg donors and sperm donors, again, that particular group, embryo donation, all these go into 3. So whenever a patient comes in, if you have a quick tick mark, we have an Android, Android phone, those who have it, this can be actually down.
Score is available.
And you can calculate the score. And if the score is 3 and above, just close your eyes and start 75 milligrams of low-dose aspirin. Now, 70 is a constant controversy, but currently even the aspirin people have said they don't have a trial to see whether 75 is better or 150 is better.
Yeah.
Recommending 150, we are still saying so 75 milligrams plus 1.5 grams of calcium. And this definitely now this has been validated. Dr. Meeta from Jammu has done that beautiful study. She's validated the specificity, sensitivity, and it's already in the Jogi Journal, May 2022. So all medical colleges are doing the thesis. So we would say Gestosis score is a simple, easy, reliable test available everywhere, and anybody, even the simple interns and nurses, can also do it. And now the test, one more test I'd like to tell you about is a Congo red test, where suggested that women who are having preeclampsia, that urine contains misfolded proteins. So if a Congo red dye is added to that, this Congo red dye, it's an azo dye, it joins up to the amyloid fibrils and gives a positive red test. So if this test is positive, this patient will develop preeclampsia. So WHO has currently done this study in Bangladesh and Mexico. It's yet to come out into our part of the world. So that still is there. And there are many research tests which are going on. But today, what we see as a most promising test is the Gestosis score.
Amazing, amazing. Means instead of going into all the PAPAs, the nuclear scan, the color Doppler at certain place, and all the high definition test over there, it's a very good that each and every one can do the Gestosis score and to find it out. And if the score is 3+, then it's and the score is very simple. That's a mild, moderate, and severe with several factors. Just tick it out and find out. That's amazing. And the Congo red, which you are talking about, it's another future of the thing. Amazing, amazing. So once we diagnose it in the right time and the right thing, it's very important. Now, can you put some tips, or would you like to talk about the usage of Maxelf and the role of Maxelf in a neuroprotection, which we all talk about? So I think that will be in a crisp way we can give some take-work message to all the listeners.
See, magnesium sulfate is a wonder drug of this century. It has been used since 1980s in India, but it was only after collaborative eclampsia trial that everybody accepted, because there's a huge RCT done. Today, we say Maxelf is the gold standard for prevention and treatment of recurrent conversions. So whether you give it by the Pritchard's regime, whether you give it by the Susspan's regime, it doesn't matter. In corporate hospitals where it is possible to have infusion pumps, this is much more kinder to the patient because it doesn't give those gluteal abscesses and it's not painful. But in the medical colleges where infusion pumps are not always available, you can follow the standard Pritchard's regime. But remember, the loading dose is the same, 4 grams IV, looking at the clock, 15 minutes, and then 5 grams every 4 hourly, which you are going to be doing if you're doing the Pritchard's regime. Of course, in the Pritchard's regime, the total loading dose will be 4 plus 10, that is 14. And in the Susspan's regime, it is 4 plus 1 gram per hour. But remember, it has to be given for 24 hours. One important tip which I would like to say, Maxelf definitely gives a neuroprotection in the gestational age of 28 to 32. And the delivery is imminent within 24 hours. But if you give it later on, we still don't know whether it really has a beneficial effect. But what has been seen in Surya, we have a big NICU. It has been seen that the neural outcomes, neuroprotection is definitely there in these smaller babies. And when you are using it for preeclampsia eclampsia prevention, or whether you're using for neuroprotection, you have to monitor it. So the respiratory rate, the patellar reflexes, and the urine output are very, very important. If you monitor these clinically, this has been shown to be superior to your biochemical monitoring. So keep Maxelf. It is easy, cheap. Store your maternity units. Do the eclampsia drills. And Kavita, we've been doing it for so many workshops and so many places that eclampsia drill should come just like that. And one more important thing is today we have a ready-made IV Maxelf, which is
it's evident.
That is easy. It doesn't cost too much of a memory. And quickly you can give it.
And it can be given easily.
Continue for 24 hours. But once you know it's a severe preeclampsia and there is an imminent eclampsia, the Maxelf prevents the patient from getting convulsions, keeps her in a conscious state, relaxes her, is a cerebral vasodilator, peripheral vasodilator, but you still need antihypertensives for prevention of the stroke. So those are important take-home messages.
Amazing. Sorry. Yeah, continue.
And Maxelf, in the good old days, patient used to be unconscious, but today patients are conscious. Yes. Babies have got much better outcomes.
Yeah, amazing. So you can say in last 10 years, the use of Maxelf has been widespreadly being used by all, and availability is also there, and intravenous will change the trend of this thing. Will you like to talk something about the current antihypertensives?
Right.
So when we were students, the antihypertensives were the different one. But what the new one, what should be the take-home message for all?
Right. Yeah. See, for the non-severe, we are still saying labetalol and nifedipine both can be used.
Yeah.
We used to like methyl dopa for this particular non-severe variety, but it's no longer available. And the new drug which has entered the armamentarium is nicardipine. So this is the same family as nifedipine. So this is for the non-severe. But for the severe, you have the IV labetalol. You can use anything, the Parkland regime, or you can use the Cibai regime, whichever way it gives good results. But remember, the pulse rate has to be more than 100. If there is a bradycardia or if there is CCF or diabetes, then it is better to use nifedipine. But one important message I would like to give: whichever antihypertensive you are giving, give it with the understanding that there is going to be time for the effect. We want to lower the BP promptly, but not rapidly, because the precipitous fall is dangerous, and never give nifedipine sublingually. So whatever you're using today, labetalol is available as 100 BD, as 200 BD, as 200 TDs. You can go right up to 200 4 times a day. But to step in and add nifedipine. And when you're telling patients that use these drugs, time, label kar do time ka. 7 o'clock, 8 o'clock, give them the timing, because then they will take it correctly. So if you're using one drug, then it is easy to label the time. If you're using 2 drugs, again, put the timings and tell the patient when she should take her BP. So she's coming to the daycare center, the BP can be taken there. If she's got a BP machine at home, she can monitor and she can send all this by WhatsApp to you. But that monitoring is very important. And all these drugs have got side effects, but finally, we have to see if the patient is benefiting, how is she benefiting? And then you have to decide, do you want to really deliver her if she's not responding? If her period of gestation is adequate, you've given the steroids to her for lung maturity, then you consider delivery.
Amazing. So labetalol, nicardine, or nifedipine is in the queue, you can say, and the timing is very, very important. The one drug or the true drug, the timing. So when should you actually deliver the patient of severe preeclampsia? When you want to deliver? I think few more questions and suggest.
Yes. In the non-severe, where the BP is well controlled, even if the patient is on antihypertensive, you've done your monitoring and the fetus is growing well, the biophysical profiles are good, you can safely go up to term. You can 38, 39 weeks, you can allow them to go into spontaneous labor. But at any time you feel that the BP is rising or the baby problems are there, Dopplers are there, consider delivery and deliver them. But in emergency situations where the BP is really very high, what we call a severe preeclampsia, in that you give your Maxel, give your antihypertensives, stabilize the patient, give her the steroids, and consider delivery. In the preterm preeclampsia, that's a problem where, the life is at stake. You want to save the mother, you also want to save the baby. In those situations, you must consider delivery imminent, but stabilize the patient. If she is not in a tertiary care center, consider moving there. But before she shifts there, put in an IV line, give her the injectable Maxel, give her the labetalol, and then only shift her. But in those cases, you have to deliver much more. Yeah, and there, if you have to do a section, remember the uterine segment is not well formed. So the thick segment, say you have to take out that preterm baby. So make sure you have a good experienced assistant with you. You have availability of blood, labs are there to support you, and a good NICU to take care of the baby.
Amazing. Yes, you are absolutely right. This depends upon the hemodynamically stable patient or unstable patient. If it's a stable patient, we can deliver it with the planning. And if she is not stable, then we have to make her stable and deliver it as early as possible with such a center which is having all the facilities available about the blood products, the NICUs and everything. Amazing. So what is the best anesthesia which you suggest? Because this is another question from years together we are talking about ki GA dein, ki spinal dein or whatever. So what best anesthesia you suggest about? And followed by, we will conclude it with any postpartum management which we like to do. Yeah.
So in HDP, the best anesthesia is regional, either spinal or epidural. The only time you give a GA is when there is status.
There's eclampsia.
When the patient's BP is very high and she is just fitting, you've given the Maxel, those are the times. And if the spinal fails. But remember, for the spinal failure also, there is a drill. Even the GAs are difficult. So an experienced team is very necessary because these women have got short necks and they've got hypertension, vocal cords are edematous. So they can be very difficult. So that's why regional is always preferred. And one thing I'd like to say that post-delivery monitoring of patient is very essential. Just because you've delivered the baby doesn't mean the patient will not throw a fit. So continue Maxel for 24 hours, continue your BP monitoring. And we have also suggested that they should get flotrons and low molecular weight heparin 6 hours. If you've given regional 6 hours, 6 to 8 hours after that, because these patients are quite edematous, obese, and they can have DVTs also. And then once they've stabilized, mobilize the patient as soon as possible, monitor the BP. When you're discharging them, make sure you've explained them how to take the BP measurements and call them back every third day or let them measure the BP at home and let you know. And sooner or later, shift her from that big labetalol dose to the smaller doses. Maybe an amlodipine can be a good option. But if you find after 2 weeks, the BP is still persistently high, refer her to a physician, a cardiologist, check the renal plus renal Dopplers after 6 weeks. And if she is obese, lifestyle changes. And Kavita, one last message which I'd like to say is, these patients of preeclampsia can conceive at a drop of a hat. So contraception बहुत जरूरी है. If they want to conceive again, they must consult their physician or the gynecologist for a preconception counseling. So we can take it from there. So बिल्कुल भूलिएगा नहीं.
Amazing, amazing, amazing. The way you put the anesthesia is the way it should be. And the same with the postpartum management. We have seen in the last few years that there is a decrease over the years of the eclampsia and probably the hard work of OB/GYN, and especially you people who are working very hard into the field of hypertensive disorders of pregnancy. Probably this is the one of the reason, and the maternal mortality because of the eclampsia probably has gone down. Otherwise, also the maternal mortality has gone down of this country. So we're really proud of all of us to work hard for the subject of hypertension. And you people are doing amazing work into the hypertension. So congratulations and thank you so much for being with us. And
this just one line. In atypical preeclampsias, or if you is out of turn and has convulsed, we mustn't forget the autoimmune problems. So investigate them, because those are the ones which can lead to preterm, convulsions and preterm abruptions. So we have to investigate for the autoimmune bit in those particular cases too.
Amazing, amazing. Thank you so much. I think everyone over there will enjoy the conversation, and thank you so much for being with us. Thank you.
And all the best to you for your presidential.
Thank you so much. Thank you so
much. Thank you, Bapat ma'am, and thank you, Suchitra ma'am, for the wonderful dialogue that we had. And it was such an enlightening dialogue that we had, all those practical tips, what we learned right from the residency till what we have got now. So now thank you so much for being here today. Moving on to the next session, I would like to invite our chairperson for the topic imaging and endometriosis. The speaker is Dr. Kuldeep, sir. So our first chairperson is Dr. Brajbala Tiwari ma'am. She is the president Indore OBGY Society 2022-23. She is also the vice president for Indian Medical Association Indore, Indore Menopause Chapter, secretary for ISOPAP Chapter Indore, joint secretary for MPSA 22-24, organizing secretary MPOC 2018, and also the organizing joint secretary AICOG 2022 and ISA 2023.
This is enough.
She is the consultant and infertility specialist and managing director for Santati Life Care. She has organized many live surgical workshops. One of the famous, always what we have is the Osama Shoki workshop, what we have with Brajbala ma'am. Faculty in the National and International Conference and recipient of CS Dawn Best Paper Award. Next, please. I would like to invite Dr. Jyoti Banglawala ma'am as the chairperson for this session. She has 26 years of experience in OBGY and Gynac. She is currently the Vice President Indore Obs and Gynae Society 22.
It is enough,
Secretary Indore.
Kalyani.
And our favorite is Jyoti ma'am. No, ma'am.
It is enough. I am the Vice President of Indore and जहाँ पे 3 big B's है.
I welcome you, both of you. Ma'am, the dais belongs to you. Kindly introduce Dr. Kuldeep, sir.
Yes, I will. And it is my humble opportunity to introduce one and only Dr. Kuldeep Singh. Dr. Kuldeep Singh from India is a master trainer in his field of ultrasound, which he is so passionate about. He practices ultrasound in New Delhi and is known for his skills in ultrasound in OBGYN and infertility. He has more than 300 talks in national and international platforms. He has been invited to share his academic experiences in Japan, France, Spain, Italy, Belgrade, Dubai, Seoul, Dhaka, Kathmandu, Philadelphia, and Singapore. He has received 4 awards and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in obstetrics, gynecology, and infertility. His books have been translated into Spanish, Chinese, and Portuguese. He was awarded the Imaging Science Award in the AICOG in Delhi. He is successfully running Sono School, which organizes various training programs in ultrasound and obstetric gynecology and infertility. He is going to be launching his latest venture, Wequal, We Question, You Answer and Learn, which is going to cater to basics and advances in academic programs. And he is so actually helpful to each and every gynecologist. Everybody can say, कि सर है तो ultrasonography सीखना ही है. We welcome you, sir, for your talk.
Thank you. Thank you so much, Dr. Jyoti. Thank you so much. Thank you, Dr. Brijbala. If we can stop sharing, then I can start sharing my screen, because then we can. I hope everyone can see my screen.
Yes, sir.
Yeah.
Right. So we basically going to go on to Let's Scan Endometriosis, and I'd like to thank the. We have big B's, so over here we have big 3 B's, Dr. Bapat, Dr. Bakshi, and Dr. Basid, and plenty of the society helping out. That's really amazing, and everything going pit-pat. And thank you, Dr. Kalyani, for organizing all this as well. We're going to talk on Let's Scan Endometriosis, and I've made it like a 10-pointer. If the slides don't move or there's some problem, do let me know. So we're basically going to understand when to suspect, which modality, which technique, the indirect clues, the commonest appearances, the variations, where all can you look in for, the mobility, soft markers, and staging. Again, that's more of a theoretical slide, but yes, estrogen-dependent disease resulting in substantial morbidity, pelvic pain, multiple surgeries. It could lead to impaired fertility as well. Presence of endometrial-like tissue outside the uterus. The imaging modalities currently used to diagnose the presence, the location, and the extent of endometriosis. And what we have is sonography, double contrast barium enema, magnetic resonance imaging, and I'm more into sonography, so I'll be mentioning much more about the ultrasound perspective. We all know transvaginal sonography is the first line imaging technique, not only because of its availability, low cost, patient acceptability, but it's one of the most accurate diagnostic modality in the majority of cases of ovarian and extra-ovarian endometriosis. A word of caution for all, TVS is fantastic. It has a much better resolution, but do not forget that when the patient comes to you for the first time, please do a trans-abdominal scan because the transvaginal scan has a limit to penetration, while in terms of mobility, you would be able to move your transducer on the fetal abdomen and looking for all these things. So that is how first time the patient comes, please do a transabdominal scan and then follow up with a transvaginal. Now, there are a few conditions where MRI would be a little more helpful. A setting in which MRI potentially more beneficial is the ureteral segment, involving the distal ureter, the 3 to 4 centimeters above the VUJ, a location which may not be easily visualized at ultrasound, but more consistently with MRI. 28% of patients with are in terms of a sigmoid, deep in disseminating endometriosis, they would have associated ileocecal disease. The evaluation of the ileocecal region with MR is always a little more helpful. So you need to be watchful for all this. Endometriosis, a common chronic gynecological condition. It can manifest in 3 ways. Superficial, where you're looking at peritoneal disease, ovarian disease, where you're looking at endometriomas, and DIE, which is deep infiltrating endometriosis, most complex and surgically challenging. Various locations where you can see ovarian, one of the most commonest areas, you could be looking at in the retrocervical, deep bowel, bladder, and abdominal wall, especially when you're looking at a scar area. The 4 components of a dedicated transvaginal protocol for the evaluation of pelvic endometriosis. You need to be starting off by looking at the uterus and the adnexa, the evaluation. Dedicated search for deep infiltrating endometriosis, assessment of the sliding sign. That's where transvaginal is extremely important because it's going to be on a dynamic platform. The detection of sonographic soft markers. We have static findings, we have a dynamic TVS. Static would mean it's not going to change. We do not need to be moving the probe as such. So for looking in for adenomyosis, endometrioma, hydrohematosalpinx, and hypoechoic nodules. Dynamic, where you're looking in for adhesions, where you're looking in for obliteration of the POD, the organ mobility, the site-specific tenderness, and tenderness-guided imaging. But you need to be very watchful. You need to be gentle with the patient. You need to be telling the patient exactly what you're going to be doing, and don't be rough and ask them because then it's going to hurt them everywhere and you're going to lose the plot. So be very gentle so that the patient is with you. So we're looking at the uterus and the adnexa, the DIE, the sliding sign, and the soft markers, which I'm going to be showing you with plenty of videos. You could be looking at superficial or deep. With superficial, the deposits of endometrial tissue are attached to the peritoneal surface without invasion. In DI, it's greater than a 5 millimeter extension with organ invasion. The accuracy of TVS for the detection of endometriosis in the pelvis is location dependent. Where exactly, how far away is it, and how you're going to be tackling it. If you have an endometrioma, it will be diagnosed by ultrasound in 80%. Ultrasound, a perfect examination for cystic ovarian endometriosis. Specificity, very high. If we see clinically, only the ones that are more than 2 to 3 centimeters can be felt. In terms of this portion, only the lower situated and larger deep endometriosis can be felt. The larger only 50% and the smaller are going to be felt in 4. So ultrasound will detect the larger and the lower situated deep endometriosis. but it has difficulty with the higher lesions, again because of the transvaginal scanning. If you're looking at a previous surgery, things could again be a little difficult. On a TVS, you have the ability to dynamically assess the mobility and the site specific tenderness, which is a soft marker for endometriosis. The moment you have the loss of the sliding sign on a TVS, basically means there's an obliteration of the POD, an essential piece of information that if we're doing the scan to let to know the laparoscopic surgeon, or if you yourself be going to be doing it, that's the information you're going to be having. The nodules of endometriosis can appear as solid, hypoechoic, or irregular masses, which could contain echogenic foci, small cystic spaces, and would show little or no blood flow on Doppler. We have the International Deep Endometriosis Analysis, the IDEA group, which basically shows up how you're going to be looking at the first step, seeing the uterus and the adnexa, sonographic signs of adenomyosis, looking in for endometriomas. Second step is soft markers. Third step is doing the sliding sign to see the status of POD. And the fourth would be assessing the DIE nodules in the anterior and posterior compartment. Now, what do you see as a sign in the uterus? We're going to be having a so-called adenomyosis, but that does not say that there's going to be endometriosis as well. But if you're looking at an anteverted retroflex uterus, that's a question mark sign, which I'd put it up in all the Sono School groups as well. You can see it with severe posterior compartment, deep infiltrating endometriosis. That's the question mark sign. I purposefully tilted this image so that you can see how it looks like. That's a question mark sign over there. A typical endometrioma would be like a unilocular cyst with regular walls, homogeneous, low-level echogenicity. That's the ground glass appearance. You could be looking at hyperechogenic wall foci, which is again seen in endometriosis, and you would not see any blood flow over there. That's a color score of 1. That's how an endometrioma. This is pattern recognition. The moment you see this, what's going to ring in your mind is an endometrioma. Ovarian endometrioma, and you can see all the chocolate there. You could be looking at septations. They are a frequent finding, but don't worry, don't get alarmed. We're not looking at malignancy because in a malignancy, the septae are going to be much thicker and there's going to be blood flow in the septa. The wall of the endometrioma is usually smooth, but you can see sometimes irregularity or frank papillary projections. We know this is endometrioma and it was proved otherwise also. These were the septa we were tending to get worried about. Did a Doppler, nothing seen over there, so we were comfortable. Endometrioma. They may undergo decidulization in pregnancy. Again, you can confuse it with the mass over there, or if they are in the pouch of Douglas, both of them, you're looking at kissing ovaries, seen posterior to the uterus and seen with bilateral endometriomas. The moment you see something like this, do not get panicky. Just switch on your color. If you're not looking at it, reduce the PRF, reduce the velocity. Switch on your power angio, the same that you do for endometrial or perifollicular flow. And if you do not see any flow, you're comfortable about it, do not need to panic. We're looking at, that's the uterus, and we're looking at the kissing ovary sign, and we're looking at loculi behind the uterus as well. Kissing ovaries, that's the uterus, that's the endometrium, transverse section, right ovary, left ovary. So the moment you're hunting or you're looking in for adhesions, they can be found far away from the true adnexal site. So how you're really going to be looking at, apply gentle pressure and try and see the cyst on the screen, whether it's moving or not. How is it with the other structures as well? That is what is called the sliding site. Kissing ovaries I've already spoken about. That's the idea group looking in for the anterior compartment. You could be looking at endometriotic spots, bladder dome, bladder base, ureter, or there could be a complete obliteration. Posterior compartment, again, you need to be watchful, and I'll just explain you with a few short videos how you're going to be doing it. You're looking at the uterus, that's the posterior surface. The moment you're moving your probe in and out, that's a specific movement in a TVS. You can see the rectal surface moving separately than the uterus. So there is no adhesion over there. You are comfortable about it. The moment you're going to be putting your hand on top in the bladder, in the pubic area, again move the probe and you're going to be seeing the bladder moving separately. See that now. I'm pressing from here and moving the probe. And there is no adhesion over there in the anterior area as well. Patients with endometriosis of the posterior cul-de-sac can have atypical non-cyclical symptoms. You could be looking at various nodules which could be solid, spiculated, non-compressible masses seen in that area. Separate from the ovaries, you're seeing that in the cul-de-sac, in the POT. You could be looking at a hydrosalpinx. Looking at the bladder, the deep infiltrating endometriosis can be seen at the bladder base, bladder dome, and it's seen as hypoechoic lesions. That's a 3D, that's the bladder over there, and you're looking at a mass. And she used to have problems in the urinary compartment every time it was like 3 to 4 days before her periods. That's the mass seen inside the bladder. Ureters could appear dilated. Dilatation of the ureter due to endometriosis is caused by a stricture from extrinsic compression or intrinsic infiltration. This region can be obliterated. Up to 1/3 of women with a previous cesarean section can have adhesions in this area, and you can find out by the sliding sign. See over there, that's the uterus, that's the scar area, and you can see this portion coming up over there. Not very vascular. You can see the break in the continuity on the anterior portion where the scar area is. You could be looking at a nodule in the rectovaginal space below the line passing along the lower border of the posterior lip. You could be seeing a thickening of the vaginal wall, which again, we're not going to be appreciating that much. But if you're looking at a nodule, you need to be watchful. Moving the probe again, sliding the probe, trying to see this area specifically. There is an endometrioma, but you need to be looking at the other areas as well. Nodules can be single, multifocal, can be resembling a comet, various positions that you're looking at, a moose antler sign, Indian headdress sign, depending on how you're looking at the posterior involvement. Site-specific tenderness. You need to be doing a dedicated evaluation of these sites. The moment the patient says it's hurting, be careful, looking at that area completely for adhesions or for small nodules. You need to be appreciating the ovarian mobility. The uterus and ovary should be separately moving. The ovary should be separately moving from the bowel. If there's fixation, it could apply that there are adhesions. You need to apply gentle pressure over there. That's how you're going to be looking at. you're applying pressure and you can see the uterus and the ovary moving separately. The ovary moving separately than the bowel over there. Again, the staging, American Society, stage 1, minimal, mild, moderate, severe. There are plenty of these things which are going to be discussed in the panel, so I'm not going to be taking time on these things. MRI can detect, last 2-3 slides, even the smallest of lesions to looking for hemorrhagic signals, and it's superior to CT. You're looking at rectovaginal disease, MRI definitely little more superior. TVS and transrectal can reveal ultrasonographic features from cysts to complexes or looking at solid masses which are devoid of vascularity. CT, not very helpful, but again, plenty of work going on. And there would be, when we're looking at ureters, might be we start using this a little more. TVS is regarded as the first line imaging modality. The machines are getting better, we're getting smarter, and we're trying to be looking in much more. But we all need to remember it's heavily operator dependent. And that's what we always say. The eyes are going to see what the mind knows. But secondly, you need to be watchful. If anyone can do it, you definitely can do it. Final slide. When to suspect, which modality, which technique, indirect clues, commonest appearances, variations, where all anterior and posterior, mobility by looking at the sliding sign, soft markers, tenderness and ovarian mobility, and staging to looking for the extent. Thank you so much.
Thank you, sir. It was excellent deliberation. It is the main behind machine which makes everything possible. We were taught that it is the disease with diagnostic dilemma from our MBBS time, and only the diagnosis was empirical treatment with OCP and patient get benefit, or we have to go for diagnostic laparoscopy. But with your deliberation, we come to know that it is the sonography or imaging modalities, MRI, barium enema, and very practical tip that we should not jump on TVS because it is the painful condition and there is a restricted mobility. So we should do abdominal sonography, and all the signs, question mark, kissing ovary, ground glass appearance, and the sliding sign, your videos were amazing, beautiful. It is going to in our brain for a long time, and it is going to help in our day-to-day practice and making diagnosis without doing any invasive procedure. Thank you so much, sir.
Thank you. Thank you so much.
When the Kuldeep sir is there, the things are different. It becomes really simple. It becomes, though the way he put things, it becomes very simple. Thank you so much, sir. Thank you so much.
He stuck to our tagline, learn simply.
Learn simply, yeah. It goes with, it goes with us.
Imaging simplified.
Correct.
Very true.
Sorry.
Yeah.
I was here only. I just switched off.
Yeah, Dr. Kalyan.
Yeah.
Thank you. Thank you, Kuldeep sir, for the wonderful lecture. It was such an...
I'm here. No, I'm there. I'll talk. Yeah.
Ma'am, can we? Yeah, okay. So thank you, Kuldeep sir, for the wonderful lecture. And it was, I shouldn't say it was a lecture, it was an eye-opener. I think it was the practical tips which we all could hear about, we could see about. So like ma'am said, it's just learn simply. So it was just, a treat to our eyes as well as our ears that we could correlate everything together. Wonderful lecture. Thank you so much, sir.
Thank you. Thank you so much.
Thank you, sir. Thank you, Jyoti ma'am and Brajbala ma'am, for chairing this session. Now, moving to our next session is the panel discussion. Mr. Pankaj, can you share the slides, please?
Just give me a second now.
Sure. So moving to our next session, the panel discussion is on tackling endometriosis in different scenarios. So when we were making the program, we were all discussing, what should we have in the panel? So the most common answer what we got is, okay, let's just discuss about all the different scenarios what we can have in an endometriosis. right from different age group, right from different scenarios, what we have with us. So the moderators for today is Dr. Archana Basair ma'am and Dr. Asha Bakshi ma'am. I think our slides are not starting.
Ma'am, can you share that slide, ma'am?
One second. You want me to share on your WhatsApp?
No, ma'am. Can you share it on this platform, ma'am?
I am actually.
Kalyani, no need.
What we can do, Kalyani, we know everyone by heart. Everyone's
Ma'am, so I'll just give a little small brief. So let me introduce Dr. Archana Basair ma'am. Ma'am was the past Vice President FOXI 2020, Organizing Secretary for AICOG 2022 Indore, past Fellow Representative AICC RCOG West Zone, and Imaging Science Committee Chair, Suffolk, and
please mute Dr. Bharti. I think there is a lot of disturbance.
Okay. Yeah. She's also the Guinness World Record holder for removing of the largest uterine tumor. So I welcome you, Basair ma'am, to
Brain Master of AICOG. Brain Master of AICOG.
Oh, yes.
Thank you.
Correctly
Thank you,
said.
Dr. Bapat, for the kind words.
Bakshi ma'am, like I said, needs no introduction. She is the lead consultant at Motherhood Hospital in leading the Dr. Asha Bakshi Fertility Center. She's the Vice President-elect 2022 West Zone FOXI, Treasurer ISAR, member of the Executive Committee AIC RCOG West Zone, and founder chairperson for MPAIG and MPISAR. Multiple chapters, multiple conferences done, organizing secretary for AICOG. So I welcome you, ma'am. I welcome Basair ma'am and Bakshi ma'am both, and to lead this moderation for today's panel discussion.
Adorable senior of the town.
Wow, thank you.
She is actually a legend. She's actually a legend.
Adorable legend of the town.
Yeah.
Sorry.
Yeah. So next. Good evening, everyone. And please allow Dr. Bakshi to share the screen so we can move on with our panel. And we have very esteemed panelists with us. None other than, the three of them have been in the endometriosis committee and endometriosis. Dr. Bakshi, would you like to share your screen?
Can you see?
Yes, we can. And then
yes,
we will just...
Archana, are you introducing the panelists? Are there?
I am introducing because I think he can't put the slides. So I have three I will introduce and...
Ma'am, just give me a second, ma'am. I'm sharing that slides.
So shall I stop sharing?
Yes, ma'am. Yes, ma'am.
Otherwise, we have it on our WhatsApp and we can...
No, ma'am. I just give me a second, ma'am.
Otherwise, a single liner for all of them I have.
Exactly, not single liner.
Remaining things are there, like Dr. Ramani Devi is a queen of endometriosis world.
Dr. Ragini Agarwal, she is always on move.
No, Ragini Agarwal, madam, is a leader of leaders.
And a very good speaker. The way she speaks is so really very good.
Bold.
And Asha Rao, madam, is there or not?
She is there. She has logged in.
Let her come. And the Bharti is the master of Karnataka. She is the boss. She has worked tremendously well in the last 2 years as a Hassan Society and a secretary of Kasoga. She is a person there. Asha Rao, I have
Thank you, Dr. Kavita.
Hello, everyone. This is Dr. Vidya Thobi from Kasoga.
Asha Rao has got the word. She is the same like Asha Bakshi of Indore. She is a legendary person of Coimbatore.
Thank you, Kavita, my dear friend.
So shall I read about Dr. Ramani Devi and we get on now? We have Dr. Ramani, are you there?
Yeah, I am very well here, Archana.
Oh, Dr. Ramani is a great friend. She was my co-vice president in 2020. And I think endometriosis and Ramani Devi are synonymous.
Yes.
Because so many publications on endometriosis and she is the leader. And she has so many awards, and every now and then we know that her publication is there about endometriosis, she has been recipient of several awards, especially to mention Dr. C.L. Zaveri Symposium. She has Best Women Doctor Award by Tamil Nadu, ICOG Special Appreciation Award, and she is Executive Committee Member of Endometriosis Society of India, editor of FOXY GCPR on endometriosis. So welcome you on board, Dr. Ramani Devi, for this panel discussion. We are really looking forward to inputs of all the stalwarts of endometriosis and gynecology here for this panel discussion on different scenarios. May I have the next CV, please? Dr. Ragini Agrawal, again, she was my co-vice president FOXY in 2020. Ragini is a very bold, dynamic gynecologist. She is a founder president elect of North Zone, and she is a president of Haryana Obs and Gynae Society, and she is a project leader of GOGS and many awards to her kitty as well. So welcome you, Dr. Ragini, on this panel, on this platform for our panel discussion, and would be really happy to have your inputs and bold comments on the cases which we have brought across. And she has several orations, and the two main award is her PJ Abdul Kalam Award for Academic Excellence. So may I have the next CV, please? Dr. Vidya Thorby is a good friend, and now she has recently been elected as Karnataka Society of Obs and Gynae Association President, and she's Professor and Head Department Obstetrics of Gynecology, College Vijaypur. She's been Chairperson, Food, Drug and Medical Surgical Equipment Committee, several awards to her as well, and she has been ICOG Governing Council member, and she's a postgraduate and undergraduate teacher for more than 30 years. Over to you, Dr. Bakshi, to introduce Dr. P. Das Mahapatra and rest of the panelists.
Dr. P. Das Mahapatra is a dynamic person. I've seen him working in the AICC RCOG, and I know how good he is. And he's dedicated to the field of endometriosis. So, Archana, I think he's the right person, and he's going to give us lots of take-home messages. He's director of Spectrum Clinic and Endoscopy Research Institute, Kolkata, and honorary consultant, Kothari Medical Center. He has been ex-chairperson AICC RCOG committee, and examiner for MRCOG and FRCS at Edinburgh, President Endometriosis Society of India, Vice President Indian Endoscopic Society, Founder President Medical Education and Research Society of India, and overall he's a very knowledgeable person, and his inputs are going to be very valuable.
One more thing I would like to add.
One liner by me. He's a backbone of the AICOG, is a silent worker. We have all seen.
He is
welcome, sir. Welcome.
Academics. He's a Mountaineer Association president.
I know.
And he's a holder of pilot license as well.
So great. Very
unusual to see gynecologists having all those things. Yeah.
Welcome, sir.
Another panelist is, I think, Dr. Bharti Rajshekhar. Dr. Bharti Rajshekhar is medical director and OBGYN consultant from and has been president-elect of Kasonga, and she comes from
Hassan. You can cut short. I'm from Hassan.
And she has been vice president of KPMEA State and Indian Red Cross Hassan's director. She has been actively involved with the IMA, and in Hassan Obs Gynae Society, she has been president and secretary, and also in PCPNDT, she has been a member in that committee, and she has done lots of work for FOXY Foods and Medical Equipment and Drug Committee member, and many other oncology, public awareness, and she has been a trainer for FOXY DIRA program, trainer for FOXY RAC program, and she has been member of AHPI, HSSP, and she has several awards to her credit, and especially President Medal from as topper in MBBS Madras Society. And she has a special interest in adolescent health and pregnancy, preventive oncology, geriatric health, and family welfare and contraception. Welcome, Dr. Bharti.
Thank you. Thank you, Dr. Asha.
And next is Asha Rao. And very interesting is that Asha and myself, we share the same name, and not only the name, but also the same birthday. So that's a good coincidence. And her son and my son both are endoscopists. So she is very popular and director of Rao Hospital, Coimbatore, and she is very much involved in academics. And we all have visited Coimbatore and seen how nice CMEs she does in Coimbatore. And she has affiliations to many societies. And most important is she is chairperson endometriosis committee, and this committee comes under my vice presidentship. And she has been past president Coimbatore Obs and Gynae Society, and has many publications and research. And we have seen her working so much on endometriosis, and especially the last month was Endometriosis Awareness Month. And so many activities she has done, and she has been a gold medalist during her MBBS.
Thank you, Asha, for those kind words.
Yeah. So, Asha, welcome, and it will learn lots of points from you. Thank you so much.
Welcome, Asha, madam.
Thank you, Kavita.
Now let Dr. Bakshi share her screen so we can begin with our panel. Please.
Has Thorby already been introduced?
No, introduced. We have to start our panel and cases Dr. Bakshi has in her.
Yes, Rachna, go ahead. Archana, go ahead.
I think we move on to the next slide, which I think already has been introduced all the panelists. So welcome. So dear all, we know that endometriosis is a costly chronic disease, and
I thought it is CCD, Cafe Coffee Day you are talking about, CCD.
Yeah. And it is basically, it affects all age group of women, let it be adolescent to even perimenopausal, and you will find endometriosis really, it affects the life of women. So we have brought a few cases here, which will really have different, inputs from all the panelists, and very day-to-day practice cases are here, which all of us have seen in our practice. And sometimes we get baffled by, how really to manage and what treatment to offer to these women. So our first case is Mrs. KV. She's 36 years. She had a one cesarean section 7 years back. She presented with dysmenorrhea and secondary subfertility. Her routine blood biochemistry all is within normal limit. Her AMH is 4.34. Ultrasonography on day 3, what we found that there's an adenomyosis, and there's a right ovary, there's a 2.5 centimeter endometriotic cyst. Left ovary is normal. Husband semen analysis, 38 million count with 60% motility. No medical problems to both the partners. So next slide, please. This is the adenomyosis, which we found on ultrasonography, which Dr. Kuldeep has just recently also told us about the question mark sign. So it is a globular shape, ill-defined endomyojunction, linear striation, and myometrial asymmetry, just to update a little bit on adenomyosis. May I have the next slide, Didi? And this is just an endometriosis, which is a very small endometrioma in her, one of the ovary, other ovary is normal. So my question to the panelist is, next slide, please. So what more investigations, Dr. Asha Rao, would you be offering to the couple? We know they have adenomyosis, endometriosis, one child before, and now they have come to you for solution, and they want treatment for their secondary subfertility.
Thank you, Archana. Very interesting case. This is a woman who is presenting with subfertility, previous cesarean. She has got good AMH, normal male factor. She has adenomyosis, no hydrosalpinx as seen by ultrasound. And one ovary has a cyst of 2.5 centimeter chocolate cyst. Other ovary is normal. In view of her, I think her age is also 34, right?
36, yeah.
36 years, yeah. In view of this, I would suggest that we offer her IVF. And since one ovary is normal and AMH is good, I would like to go in for IVF first, collect the eggs, make embryos, vitrify them, and then suppress her for 3 to 4 months with GnRH analog, do a pre-IVF histoscopy, and then transfer the frozen thawed embryos.
Thank you. Dr. Ramani, would you be advising her laparoscopy, fertility enhancing laparoscopy? She has a very small endometrioma, and Dr. Asha has said that do the freezing of all embryo and then do frozen embryo transfer. So would you be are you aligned with Dr. Asha Rao's inputs, or you would be offering her something different and doing a laparoscopy for her?
Thank you, Dr. Archana. See, I think I will agree with Dr. Asha Rao because it's a very small endometrioma, 2 centimeters, 2.5 centimeters. And she has got a very good AMH for her age, 37 years. So I think one choice is if the previous pregnancy has been conceived spontaneously, maybe again, we can do 2 things. One is suppress her with GnRH in the beginning, then go for ovulation induction with IUI, which may be one option if she is not willing for ART. Otherwise, I think I should suggest the patient in view of the increasing maternal age, maybe she can go in for ART, go for a frozen embryo transfer. Prior to that, we have to go for a medical management. First, calculate the volume of the adenomyotic uterus, then you try to reduce it. More than the volume, it is only the endomyometrial thickness or the junctional zone thickness, which is very, very important prior to ET. So prior to pre-IVF preparation, what are the things? There is definitely no place for surgical management in this particular case. Suppose if you are going to go for an IVF, that is especially FET, I will do the following things. First one is give GnRH analogs. Sometimes if the uterus volume is quite big, maybe I will add up with the letrozole for a short duration. Okay. Then along with the add-back therapy with progesterone, norethisterone. Then always go for a mock transfer. And the intrauterine cavity, already Dr. Asha had mentioned about the histoscopy. That is very, very essential because we should know the exact, there may be alteration in the shape of the uterus and the length. So all those things have to be kept in mind. And again, if the histoscopy finds some evidence of some localized glandular tissue as we are doing it, then we have to clear that also. Then mock embryo transfer is very, very essential. Then you have to go in for a GnRH long suppression followed by FET preparation. And then you can transfer the embryos and preferably a blast transfer. Single blast will be my choice. Because in adenomyosis, already there are chances for miscarriages are going to be very high. So I don't want to go in for a multiple embryo transfer. So when will you register her for the IVF? I think this I have already mentioned it. And the problems I may face in IVF in endometriosis. Here the endometrioma is after all very small and it is to one corner where we can see all the follicles beautifully. So when we do a oocyte pickup, sometimes we may enter into the endometriotic tissue. And in case if we enter, then we have to change the needle, keep aside that and keep the eggs that are picked up separately. So then again, the problem, then we can go ahead with the routine thing. See what problem adenomyosis can cause. Adenomyosis, as we know, similar to endometriosis, causes an inflammatory condition. So the first thing is they can have recurrent implantation failure. Then the patient can go in for a missed abortion. Then the patient can have a preterm labor. And again, the placental complications are very high because there is the high chance of low-lying placenta previa, and there may be abnormal placentation, which can all lead to small for gestational age babies and because of poor placentation. So these are all the problems what we face.
Thank you very much, Dr. Ramani, for really taking up the questions. I just wondered when you said that you will offer an IUI as well, if I'm not mistaken, I heard.
Yes.
So would you be doing a laparoscopy? Because this couple had one child 7 years. they were little, taking time to come for ART treatment and have been trying in between for pregnancy. So would you be thinking of doing a laparoscopy before you do IUI in such cases to check the tubal status, or just do a hysteroscopy?
See, suppose if the adenomyotic lesion is adenomyotic uterus is not very big, maybe I can have an HSG, or we can insist if the patient complains of pain, dysmenorrhea, dyspareunia, then that is a condition where I will go for a laparoscopy. But of course, definitely I will do a hysteroscopy prior to any, whether it is IUI or ART.
Dr. Das Mahapatra, suppose if this patient has a small endometriosis in the ovary, we cannot see the small, spots of endometriosis on ultrasonography. So before contemplating IVF or IUI, do you think we should be putting in a laparoscope? I know everyone is not agreeing for any surgical management to diathermy the endometriosis, because as I said in history, there is a history of dysmenorrhea as well.
Yes, I would like to do her diagnostic laparoscopy and proceed if necessary. The reason is number 2. She had double pathology, adenomyosis plus pelvic endometriosis, or you can call it endometrioma. And secondly, she had cesarean section. We know that although it doesn't happen very often, but it can still be possible that there could be a TIVO-ovarian relation disruption due to cesarean section itself. I won't venture for IUI or IVF straightway. I'll do a diagnostic laparoscopy, and if necessary, diagnostic laparoscopy and hysteroscopy, and if necessary, I will treat the endometriosis surgically. And then, of course, because the uterus is big and she has adenomyosis, we'll put her on GnRH analog for 3 months, and then we'll ask her to try for normal pregnancy for 6 months only, because she's 36 years. And if she doesn't conceive, definitely she'll be advised to go for IVF. I find that there is no place for straightaway IVF for a lady who conceived spontaneously 7 years ago.
Thank you very much, sir. I just wanted how different opinions are there. That's what the panel is, because everyone has a different approach to the same patient. May I have the next slide? I think we are clear on this case, most of the things. So I think now Dr. Bakshi can take the second case. I think this is the case which...
Yeah, thank you, Archana. So my patient is 32 years old and she's married for 10 years with primary subfertility. She has history of short cycles and congestive dysmenorrhea, normal male factor. So what investigations would you advise for her, Dr. Vidya Thobi? Dr. Vidya?
Hello.
Yeah, yes, Vidya.
Yeah. So this patient is around, am I audible? Because
yes, you are. Yes, you are.
And I'm visible also. Yeah. Yes. This patient, she has got 10 years primary infertility and short cycles and congestive dysmenorrhea and normal male factor. So I will evaluate her basic infertility, all the parameters. She has short cycles and congestive dysmenorrhea. So I would like to investigate what are the causes for this, her congestive dysmenorrhea. Maybe it may be first thing it will come to my mind is, of course, endometriosis or any fibroids or any anatomical factors to be evaluated. I must say that 10 years primary infertility means she must have been investigated. And if the reports, if they're available, I would like to look into. So the transvaginal sonography, as you have shown here, it is 3 centimeter endometrioma, and the right ovary also shows endometrioma, and the antral follicle, only 5 to 6 antral follicles, and also there is an adenomyotic uterus. So I would like to do a laparoscopy for her.
So you believe in doing laparoscopy?
To the rectum adherent till fundus. So it is a deep endometriosis as well. So I would love to do endometriosis. Of course, I'm not a good laparoscopic surgeon. I would like to call either Ramani or Bharti or Asha to my place. Two Ashas are there for my help, so I can call there when I put the laparoscope. And I would like to, first surgery is the best surgery. Whenever we talk of endometriosis, the first surgery is the best surgery. And I would like to bring in a best surgeon in my, in the medical college to clear off those adhesions and maybe ovarian cyst. I would like to strip off that ovarian endometrioma. And it is a bilateral again. So, and that thing I want to manage.
So you are more in favor of laparoscopy. Dr. Bharti, her enteral follicle counts are less.
Yes, they are also less.
So would you go for laparoscopy or would you go for IVF?
What is her AMH, Asha?
AMH is 1.8.
1.8 it is. Yeah.
Yes, yes, Dr. Bharti. Yeah.
Yeah, thank you for having me here. And because her AMH is low and her 10 years of married life, of course, I would go for an ART. Maybe we could counsel them and give them the first choice for IVF, keeping in mind that the removal of the cysts in both the ovaries may further reduce her AMH levels. But before that, we would do a hysteroscopy. Of course, hysteroscopic assessment will have to be done and probably take her up for IVF if they are willing. And of course, stimulation and frozen embryo transfer would be the first choice. If they do not agree for IVF...
Bharti, these days such good transvaginal ultrasound are available and 3D, 4D ultrasound. So in that case, do you still want to do hysteroscopy for all your patients if you have done a good transvaginal ultrasound? Cavity seems to be okay, though it is adenomyosis. Do you still want to do hysteroscopy?
Maybe not for all my patients, probably. I would not, as you said, if you have a good transvaginal scan, you have the luxury of having the 3D and the 4D, then I would not go for a hysteroscopy. But in low resource settings, when we don't have this and the sonologist's picture is not good, I think then I would just go for a hysteroscopy also along with the initial investigations and then take them up for IVF.
And maybe you want to do endometrial biopsy also to check.
Yes, to rule out
inflammation. Yeah.
Yes, endometrial biopsy when we do the hysteroscope.
Okay. So
you did not give us the details of the uterus, the uterine picture, the myometrium, endometrium has not been shown to us.
Yeah, it has not been shown.
Yeah. Now, do you think MRI is better than transvaginal sonography, or if you do a good transvaginal sonography, that would suffice?
A good transvaginal scan will suffice.
Okay. So, Dr. Ragini, what is your choice? I think Dr. Vidya wants to do laparoscopy. What would you suggest, Dr. Ragini? Ragini, are you there? And Bharti, you agree about IVF rather than going in for laparoscopy?
Yeah, I would definitely agree. Give her the choice of IVF first because of the low AMH levels.
Yeah. So there are certain indications where you may have to go straight for IVF. There are some indications depending on what are the findings, you may go for laparoscopy. But in this particular case, it looks that it would be looking at her age, especially her AMH and her enteral follicle count. It would be better to proceed straight away with the IVF. Now, in this case, IVF was done. 8 oocytes were retrieved, 7 embryos formed. Does endometriosis affect the quality of oocytes? This question can I ask to Dr. Ramani?
Yes, Dr. Asha. Endometriosis definitely affects the quality of oocytes. There is no doubt. We get the number of oocytes maybe less, and then more important is after doing ICSI. After doing ICSI, what happens is there is many of the oocytes, the embryos, there is a possibility they can get arrested on day 2 or day 3. Extended culture to blastocyst may not be appropriate. So this is probably because of the increased ROS that is found in the ovary. So definitely it affects the quality. Studies have proved that it affects the quality of the oocytes, but it is not, the abnormality is not with the endometrium. So they have found out that some of the patients where donor oocytes are used, the implantation seems to be very good. So that means basically it has got an influence upon the oocyte quality.
Yeah. So basically, we have to counsel the patient very well. That in your case, there may be a cycle cancellation. We may not get good
Yeah, I beg to differ here, Asha.
Yeah.
For very many years, we thought that it is only the oocyte which is at fault and not the endometrium at all. But today we know that there is a controversial opinion regarding the oocyte quality. Yes, you have put the evidence already that early stage it is not affected, late stage it is affected. But now there is a wonderful paper from Kamath et al. With the Abha Maheshwari, with the study of more than 1,500 cycle of women with endometriosis, comparing autologous oocytes versus donor oocyte transfers. And according to their study, they concluded that there was no difference in the pregnancy rates at all. So today there is a controversy. Whether the oocytes are, you definitely try their own oocytes. Most often they will get pregnant, and definitely look at the endometrium and do a deferred transfer and suppress this endometrium with GnRH analog prior to transfer. You will get better pregnancy rates. Perhaps we were ignoring the endometrium and we did fresh transfers, so we had less success rates. So if you have decent number of eggs like this, you should do a deferred embryo transfer, suppress the endometrium, and then do a frozen thawed embryo transfer after 2 to 3 months, and you will have good pregnancy rate.
Yeah, Asha, but you would agree that many a times the number of eggs is very less, and sometimes
you get less number of oocytes. Once you get the oocytes, the amount of fertilization seems to be similar. And amount of implantation will depend on how much you suppress the endometrium. So look at the endometrial receptivity also.
Yes.
Again, Dr. Asha, if you are going to use a long protocol, what I say Dr. Asha says is correct. Like we get a less number.
We use more and more, we are using short protocol because today we have come away from the Salam's hypothesis, which was only based on 4 studies. So somebody with
a few number of cases only he has included.
Yeah, so somebody with less oocytes like this, will definitely go in for a short protocol, collect the eggs, make embryos, and then go in for a long suppression.
So I just wanted to ask Asha that such patient comes directly without putting laparoscope. We should do direct IVF. We should send to infertility specialist. That is a conclusion, right?
Yes, that is true. That is
I wanted to bring in that. Don't put the laparoscope also. But
about 5 years back,
we stay at the smaller place. Yeah, we stay at the smaller place where the infertility specialists are not there. So usually the commitment what I told in the starting, that is the committed. If whenever such patient come, they put the laparoscope and they do the damage and then send to IVF center.
Right,
then nothing can be done. So already
about 5 years back, we would do that. We would do a laparoscopy, remove the chocolate cyst, and with that you removed half of the healthy cortex.
Half of the ovarian tissue is removed,
right?
And then AMH is reduced. And the mistake what I wanted to bring it out is they do all the damage and then send to the infertility specialist. Whatever the laparoscopic, they bring in laparoscopic surgeon and he does all the damages. He may remove the whole, both the endometriomas, then dissection, and most of the ovarian tissue is lost.
Yeah,
that is what happens.
So would you go for fresh transfer or frozen transfer? This question I'll ask to again the infertility person.
Better as the infertility person here.
We have partly answered it already.
Ramani, would you go for
we have answered. See, it is always the stage ART here, where after forming the embryos, go for a long down regulation. Because that is supposed to modulate all the pro-inflammatory factors, they get suppressed.
Yes.
So when there is associated adenomyosis, you have to be more careful. Probably we need to extend the long-acting GnRH analogs. Then here I would like to adapt.
Exactly what I said. She did not show us a picture of uterus at all.
Yeah. I'm just telling.
I see this is a very old patient, so I didn't get. I tried to get, but the images I could not get. So
if it's a focal adenomyosis, I would not worry too much. Tiny 2 centimeter adenomyosis. And rest of the myometrium is normal, maybe just suppress her for about 6 to 8 weeks and then transfer the embryos. If it's a large
adenomyosis, go about what we did the junctional zone. Junctional zone thickness is very important. in early adenomyosis also. If it is going to be less than, if the junctional zone is more than 12, don't transfer. Because you are absolutely definitely.
But that is not at all commented by the sonologist. That requires special training.
That
we need to do, get it from them. Or probably the ART consultant, we should look for that.
Yes.
So if the junctional zone is less than 8 millimeter, ideal. You
have to learn to do a 3D
ultrasound
ultrasound and a color Doppler.
Yes.
Yeah. So
And
today
preferably
you cannot be an ART specialist if you're not doing transvaginal sonography yourself. So it's very important to do it yourself. Anyway, in this patient, fresh transfer was done. The pregnancy test as expected was negative. 2 months later, this patient came with severe lower abdominal pain and worsening dysmenorrhea. And this time she said, I don't want pregnancy. You can take out my uterus, do whatever, but do something for me. So we had to plan a surgery for her. And these were the findings. Everything was frozen, and all the both the side there were chocolates and adhesions, pelvic adhesions, pouch of Douglas obliterated. So cystectomy was done, trying to keep as much ovarian tissue as possible. Luckily, we had her embryos frozen, so we were not that scared. But still, I think we have to respect the ovary as much as possible. Planes were created, ureters were identified, and ultimately, all the rectovaginal nodule was dissected, and finally, the anatomy was restored, and this was the end result. Overall, the things went well, and interseed was applied. And after that, what would you do? Would you like to give her GnRH analog?
Yes.
I think Ramani and Asha both are in favor of GnRH analog, and so
perhaps she came with dysmenorrhea because she was not given GnRH analog in the interim period.
Yes.
And many times, if the first embryo transfer is not successful, you would perhaps take her up for a laparoscopy and do exactly what you did, because she also had a lot of dysmenorrhea.
Yeah. So
one transfer without laparoscopy, the second transfer would be after laparoscopy.
Yes.
And definitely GnRH.
Sandwich therapy, what you can call as a sandwich therapy. So you take out the eggs and make the embryos, freeze them, and then do the radical surgery. So yes, GnRH analog was done, and then patient underwent frozen embryo transfer. 2 embryos were transferred, and there was a positive beta HCG. So just I want to know, does endometriosis surgery help in improving implantation rates, and does it help in improving the outcome, obstetric outcome? Would Dr. Das Mahapatra, would you like to comment on that? Dr. Mahapatra?
I would like to mention here first that nobody actually counseled the patient properly before giving their opinion. It is the patient's choice whether she wants to go for surgery or for IVF. And what is our purpose? We have to tell them the advantages and disadvantages of both the procedures. And then if one can fail, one procedure fails, then the other can be tried, because she is quite young. Nobody counseled her. Everybody gave their opinion that I will go for IVF or surgery. No. It is the patient's choice. But anyway, yes, it has been proved in different literature over the years that in laparoscopic surgery, endoscopic surgery, a woman with bowel involvement, post-operative pregnancy rate increases. She did not have any bowel endometriosis, but she had definitely endometriosis in the pouch of Douglas. There was plenty of adhesions. And women with D and bowel involvement, the post-operative spontaneous pregnancy rate was 28, nearly 30%. That is equal to the pregnancy rate of IVF. But what additional advantage we get here is that we are relieving her pain. Of course, that may not be lasting permanently, but whatever it may be, at least temporarily for 5 years, we are giving her pain relief. And of course, that has to be associated or given. She should also have some treatment for adenomyosis in the form of GnRH analog for 3 to 6 months.
And coming to the obstetric outcome, Do you think endometriosis affects the obstetric outcome of the patients?
Endometriosis as such, no, but adenomyosis, yes. Endometriosis as such, it only creates problem in conception, but it does not cause any outcome of the problem unless it is associated with adenomyosis. But adenomyosis is a dangerous thing. But unfortunately, we Asian women are having more chance of adenomyosis associated with endometriosis than the Western women. So if you think about the the Western women, they usually have only endometriosis. But here we find both almost 40% of women with endometriosis are associated with adenomyosis. And the cases so far, we have done 2 cases, and both of them were with adenomyosis as well. So adenomyosis is a great problem, not only in failure of implantation, but also even if it happens in the future, prior pregnancy progresses, she is likely to have spontaneous miscarriage, she is likely to have mid-trimester abortion, she is likely to have premature labor, and so on. Everything is possible.
Thank you. Thank you. So
I think Dr. Mahapatra has brought out a beautiful point. Earlier, we thought endometriosis caused a lot of obstetric problems, but later we realized it was because of adenomyosis, which we had not seen, which had not diagnosed. So most of the problems are because of adenomyosis rather than endometriosis.
And most of our patients do have adenomyosis. So maybe
and since we are doing most often deferred transfer and suppressing the adenomyosis, the obstetric outcome has become much better.
Yes.
Absolutely.
Today in our center, we have a collection of almost 70 to 80 cases with, I think it's about 68% live birth rate. The number of miscarriages have become much less with adenomyosis.
Adenomyosis.
Dr. Vidya, do you think these patients need more luteal phase support?
Which patient? All the ART patients.
ART patients.
Yeah.
Yes. Especially with endometriosis. There has been a study which shows that if the progesterone levels were high in these patients in whom frozen embryo transfer was done, the pregnancy outcome was better. And there are some groups who are saying that the usual dose that we give of dydrogesterone is say 10 milligram 3 times a day. So in these patients, they are recommending more than 3 times a day and maybe even 4 times a day. So that was an interesting thing that I found. So patient underwent, she conceived, she had premature rupture of membranes at 36 weeks and had fetal distress and had cesarean section. But overall, postpartum period was uneventful. Dr. Bharti, would you like to give her something so that she doesn't have, in the long term, she doesn't have return of the symptoms?
Yeah, of course. Postpartum, she may again develop endometriosis. So I would ask her to go for contraception she has to take. So I think ideally the long-acting reversible contraceptive like an injection Depo-Provera would help her to keep her pain-free and reduce, see that there is no recurrence of her endometriosis. And then later on, after a few years, 1 or 2 years, she could have another child again, if she wishes so. So she doesn't have the recurrence of pain postpartum.
Sure.
Asha, this progesterone was a little, it's quite interesting because we made a study of progesterone levels in the FET cycles in our center. And we saw that whenever it goes more than, with IM progesterone and vaginal progesterone, like the traditional method, sometimes it goes to something like 200. And these patients do not get pregnant. If the levels are between 60 to 100, 120, they conceive. This is with the IM gestone and vaginal progesterone. And with the letrozole cycles, the ideal levels are around 30 to 40. They maintain that, and we do not give any addition. We may give just 1 tablet of vaginal progesterone.
But especially if you have
again, when you give vaginal progesterone, your levels do not correlate with the serum progesterone levels.
Asha, if you have downregulated them, sometimes they do not respond to letrozole and you have to use a HRT cycle.
Because there are some patients with the, endometriosis not too much later, the ovaries are still good. So we have given them letrozole cycle because you do not have to use post-transfer progesterone injections. And they do very well just with the natural progesterone of their own. The chance of miscarriage are also much less. But we have to be very patient because you have to follow the ovulation intensely.
Okay, great.
Dr.
But
Asha,
what about the ISHRA guidelines say? Latest ISHRA guidelines, they don't support this, no?
Support
So
what?
if you are giving HRT cycle, you have to support, and you have to give a good support because it is an artificial cycle. No, if you are doing a frozen embryo transfer in natural cycle or in letrozole cycle, then you may not. But especially when it is a frozen embryo transfer in HRT cycle, then you have to. So,
Dr. Asha, I would like to share one of my patients who had borderline adenomyosis, not a very big one. Okay, she had 2 failures with implantation failure. So she came back after 6 months. I told her to get 3 doses of GnRH. Then when during transfer, post-luteal support, I gave her 600 milligram vaginally 3 times a day with 20 milligram of dydrogesterone twice a day. This cycle is conceived. So probably that is the progesterone resistance. That is the amount of progesterone resistance it is. And we also did a study about the level of serum progesterone before FET. And our results are very good when we had the levels between 25 and 40. That was the maximum level at which we got the pregnancy.
So this is what they are talking about, that endometriosis patients tend to have progesterone resistance. So this is a point I thought I'll bring up. And now over to you, Archana.
Asha, just 1 second, if I can just make a comment. You know, post delivery, why is there no role of putting in an LNG IUD? At 6 weeks, you can.
Why not?
And that works very well for adenomyosis.
It works
in
very
fact,
well.
Younger patients with adenomyosis and with endometriosis, we have sent them for freezing their eggs and then putting Mirena and telling them, okay, whenever you're ready for a pregnancy, we will help you. Because adenomyosis, as Dr. Mahapatra said, is very, very common now.
Yeah. Yes.
That is what I was
Mirena is a boon for these patients. Mirena is a boon, and these days Mirena is not that expensive also.
Yes.
So we can very freely advise, and even for routine patients, I think Mirena is a good choice.
Yeah, and fertility is not compromised at all. Endometrium blooms beautifully after removing the Mirena.
And more than that, if you have associated endometrial hyperplasia in adenomyosis patient, it is up to 30 to 40%, and they tend to have polyps also. In such LNG IUS is very, very useful. It can prevent dysmenorrhea, it can prevent menorrhagia. So my personal thing is, after always getting a baby, I insert LNG IUS.
And there is a good classification ultrasonographically for the adenomyosis uterus.
Yeah,
all the 3, and they give every classification with this. The what to be used should be nicely preferred.
I think you have to do good transvaginal ultrasonography to classify and adenomyosis or maybe endometriosis. So we are moving on to the next case, which is an example of like how you should be doing your transvaginal sonography, because if it's not done well, you may miss the endometriosis. This is a 31-year-old female, married since 2 years, with 3 first trimester miscarriages. Last miscarriage was 6 months ago. She comes to OPD keen for conception, and menstrual cycles are regular, 28 days, 3 days, but she complains of pain. She needs medication for pain control. Admission pain relief, injectables pain relief she needed. She came with a report of transvaginal sonography which showed hemorrhagic cyst and an anteverted uterus. There is no other significant medical or surgical history, no other significant family history. We move on to the next slide and see what was the finding on the sonography. But let's first, before we move on to the sonography picture, I'll ask Dr. Ragini Agrawal, she has joined back, that what investigation, Ragini, do you think you should be planning for this patient? And is there any role for EPLA? Because we are dealing here with a bad obstetric history along with the dysmenorrhea and subfertility as well.
So they don't have a trial to see whether 75 is better or 1.
Dr. Ragini,
she was there, but now she's not.
She said that she has joined back, but anyway, if she has not joined back, doesn't matter. Dr.
Dr. Bharti.
Do you think you would be planning for? I know you're not into infertility, but
yes. So One is, yes, I will do her routine investigations as well as her APLA screening. Definitely, I will go and do her APLA screening, and I will repeat the transvaginal scan once again, preferably with a high resolution machine. So that we get the exact picture whether it is she has adhesions or does she have endometriosis or adenomyosis. But the role of TOT screening, I think there's no place for TOT screening in the present protocol of RPL.
Next slide, please, Ajadi. Sorry. So we did a transvaginal ultrasonography. It revealed an anteverted antiflex uterus and endometriotic cyst of 4.4 by 3.9 centimeter in left ovary, which was adherent to uterus. And there were lots of pseudoperitoneal cysts were seen, means peritoneal adhesions, and right ovary appeared normal. These are the ultrasound picture. You can see uterus is anteverted, but it is antiflexed, and these are the pseudoperitoneal cysts. And in the next slide, we see that this was the endometriosis she has. These are the endometriomas in her ovary. Now, the question is, what should be the management plan for this patient? Now we have different opinions. Some would go for surgery, some would go for medical management. In this case, do we have a clear verdict? What should we be doing, Dr. Mahapatra?
Yes, I think she should go for laparoscopy
surgery
because the peritoneal cyst does not respond to medical therapy. We need to desiccate those cysts by any type of desiccating instruments, maybe by laser or by bipolar or by harmonic scalpel. And then moreover, she has the endometrioma, and that should be also taken out. Since we are in, it is better to clear our pelvis, and the peritoneal cyst usually also sits on the uterus. So all the uterine surfaces should be also desiccated. And then if we'll check the tubes, if the tubes are okay, we'll allow her for normal pregnancy.
So, is there any criteria, Dr. Ramani, you use, before you decide whether you should be doing medical management or surgical management for the audience, like, what cyst size? Is there any criteria? Like here, straight away, Dr. Mahapatra is saying that go for the surgery, we should remove the endometriotic cyst. And so is there any size criteria? How do you make up your mind that I know we should be asking patient as is being brought up by Dr. Mahapatra that nobody asked the patient. Of course, we should ask, but how do you, steer your counseling to the patient depending on the size of the cyst?
Archana, I'm talking about the peritoneal cyst.
Yeah.
Peritoneal cyst does not respond with the medication.
Yeah.
It has to be surgically treated.
Yeah. Again,
endometrioma, you have a choice.
Yes.
But because she has been trying for pregnancy, I think since you are in, it is better to remove the cyst. Or at least if you are thinking of damaging the ovary too much, you can aspirate the cyst. You can simply aspirate the cyst and wash it clearly with clean fluid. That will increase the fertility index.
So basically, that's what we brought this case, because there were pseudoperitoneal cysts were there, means there's a more inflammation going on, isn't it? That's why.
Not only more inflammation, but also the tubal anatomy definitely disrupted.
Things,
so,
that's what.
The first factor is pain. She wants to get rid of the pain. So that means we have to give either medical management or surgical management. But this particular patient, she has endometrioma more than 4 centimeters. Okay, again. So according to the HRA guidelines, size more than 4 centimeters, as well as if she has associated pain that is not responding, then this repeated with the previous history of this infertility and abortion, I think she is an ideal candidate for laparoscopic surgery. I agree with Dr. Das Mahapatra in this particular patient. And one more thing is, if we correct all these things, then the chances of spontaneous conception is not only increased beyond 50 to 60%, again, the chances of miscarriage are also reduced because we are all removing all these inflammatory substances, all those vesicles are burnt out. So that gives a more comfortable peritoneal environment that will promote the pregnancy.
Dr. Asha Rao, can we classify or grade endometriosis without laparoscopy?
Yes, today you have the idea group of consensus where you can look for the local factors of the uterus and adnexa. You look for the tenderness, you look for the mobility, and you look for the adhesions. You can see very nicely whether, if the sliding sign is negative, you could think that the adhesions are already there. And so if there's a chocolate cyst and if it shows adhesions, it automatically falls into something like stage 3. So if there's a tiny chocolate cyst of about 2 mm, the ovary is moving well, you can perhaps take it as minimal to mild endometriosis. So studying with ultrasound definitely helps us to guess the staging before surgery.
So, Dr. Mahapatra,
but counseling the patient once again is important, that what adhesions you see sometimes may not be so dense. You may be able to release them surgically. So you again decide on the therapy depending on patient's age and AMH.
Dr. Vidya, do you think that patients with endometriosis require an MRI prior to surgical management?
Not always.
Okay. So in which patient do you think it is an essential? Any one of the panelists can take up.
Yeah. See, sometimes in the deep endometriosis or in endometriotic cyst, sometimes MRI is required. But I must say that in superficial endometriosis, it is not at all required. So in only few cases, we can tell them to do MRI. Otherwise, if a transvaginal sonologist can pick it up, it is very good. The sonologist should be very expert in picking up this endometriosis. So routinely, we don't advise MRI. Only in a few cases of deep endometriosis and some of the endometriotic cyst, we can advise MRI.
Dr. Mahapatra wanted to make comment.
Yeah, he wants to make comment.
I think if the patient is complaining of sexual pain during period, that definitely calls for MRI investigation.
Yes. Yeah, if they complain of dyschezia.
The thickened cul-de-sac and the thickened intersacral ligament, of course, that period, you have to examine the patient during period. And if you find that there are thickened in the intersacral ligament, that calls for MRI investigation. The other point is very important, that before embarking on major surgery, before getting a specialist team for a surgery, you have to get a mapping of the disease by MRI.
Yes.
Only ultrasonography is not enough.
Yeah, if you also see a ureteric dilatation, you should also do an MRI, because you may need to release this. You may need to do a ureterolysis before the kidney goes into hydronephrosis. So strong dyschezia and ureteric dilatation, both are important indications for MRI.
I think it is very important that we are putting emphasis on transvaginal sonography. It is very good investigation. We do because it is easily accessible and all of us are doing. But there are certain cases where MRI is imperative and we have to really offer MRI before we are embarking on a surgery for endometriosis, and it might be an extensive surgery. So good to know what all structures are involved in the endometriosis. Dr. Bharati, what essential steps are essential in pre-operative planning? We did a laparoscopic surgery on this patient because she had a severe pain and she had a bad obstetric history as well, and the cyst, and there were a lot of peritoneal adhesions. So we did we removed her cyst and subjected it for histopathology. What pre-operative essential and very important counseling thing, because she's a young woman, she wants pregnancy, we are operating on her ovary. So is there anything pre-operative you would especially like to take care or talk about?
Yeah, well, Dr. Archana, first thing is I would do her AMH levels prior to surgery, and we need to counsel them and tell them that there are chances, though we do a cystectomy, there may be a drop in the AMH levels post-operatively. And the other thing is the pseudocyst she's having, so probably there may be a hydrosalpinx. And if she has a hydrosalpinx, we have to take the consent prior to the surgery that we may either have to do a clipping or we may have to do a salpingectomy to improve the outcome of her pregnancy, the next conception and pregnancy rates. We may have to do that. So we need to take the consent for this especially for the ovarian reserve, and tell them that there may be a drop in the ovarian reserve following surgery.
Thank you so much. May I have the next slide? And I think that will be the last, maybe the next, Dr. Bakshi, after this. So we sent it for histopathology, which proved to be endometriosis. And what will be the post-operative management of the patient? All of us agreed that for her, surgery was one of the best option. And how are you going to manage her post-operative? How long you will wait before advising her to plan conception? And how are you going to monitor her future? Like, are you going to do CA1 to 25? Is it helpful? So, Dr. Asha now.
Yeah, once again, Archana, we never got a good look at her uterus, but she did have adenomyosis,
show you,
which caused recurrent miscarriages,
Can we go in the, just a slide before. Yeah, this is her uterus. I think I'll bring another picture. There was not much adenomyosis.
Not a significant.
Not significant adenomyosis in her uterus.
So this lady, since it is an obvious endometriosis, I think which you also proved it by histopathology, right?
Yes, histopathology, and there was a endometriotic cyst and a few additions, not deep and invasive endometriosis.
And this lady obviously had no difficulty in conceiving. Earlier also she has conceived 3 times without any difficulty.
Yeah.
So you can allow her to get pregnant as it is naturally. I do not think you have to give her a suppression because you did not see much of adenomyosis or thickening of the junctional zone, you being a good sonologist. So I think now you have to give her a chance to get pregnant like anybody else. There is no need for very special investigations because she has conceived 3 times. The last one was 6 months back.
Yeah.
And APLA is something that you have to do because there is many patients have a combination of APLA being positive. So in case you see slightly higher levels, it's a good idea to give them low molecular weight heparin with progesterone support for the first 12 weeks.
Thank you, Dr. Asha, for bringing in beautifully like how to support her pregnancy. And Dr. Mahapatra wants to say something. Yes, sir.
May I add that she should have a test for lipoprotein A. That is a very important parameter for in bad obstetric history patients because she had 3 abortions. And if the lipoprotein A is high, we must put her into aspirin before she tries for pregnancy for 3 months. And then once she conceives, then we have to give her low molecular weight heparin. Continuously until she delivers and until 1 month after the delivery. To prevent the coagulation problem.
Thank you, sir. Thank you so much for enlightening on this. And now I'm giving it over to Dr. Bakshi for the last case.
Yeah. This case is going to be a short case, but just a 20-year-old girl comes with serious pain in abdomen and dysmenorrhea. In the past, she has been prescribed oral contraceptive pill and many other drugs which she is not able to tell the government, but her pain is getting worse. One thing I want to ask all of you, what is the youngest age at which you have seen endometriosis, Dr. Das Mahapatra?
I've seen at the age of 9 years.
9 years, oh my God.
9 years. She had her first period at the age of 8 years. And
oh my God.
Since then, she started having dysmenorrhea. At the age of 9 years, she came down to me. I advised her parents to go for diagnostic laparoscopy. Obviously, as expected, they fled with credit and they did not appear for 2 years. After at the age of 11 years, she came down to me.
Oh my God.
And I found she had gross adenomyosis along with her endometriosis in the pelvis.
My youngest patient was...
We have started believing perhaps endometriosis starts at the very, very early stage.
Neonatal.
We not recognize this disease earlier because of the lack of our knowledge. So
very interesting. Very interesting.
First onset of period.
My youngest patient is at the age of 12 years. I've seen 12 years. She had a biconjugate uterus with a hemi-side obstruction at the level of the cervix. So that was the Mullerian anomaly that was causing endometriosis. I'm happy to say that I have operated her. Hemihysterectomy was done at the age of 11 years. And it was long back and now she has conceived on her own without any recurrence. Because once when you remove the obstructive element, it goes off normally. But this particular patient with a history of severe progressive dysmenorrhea and taking OC pill, not for contraception, but for pain, it is highly suggestive of endometriosis.
Diagnosis. Bharti, you want to comment? Bharti?
In my practice, I had the first, a youngest lady, a girl around 16 years. She was a case of the unilateral renal agenesis with the hemivagina. And this girl also had a limb abnormality for which one of her limbs were amputated. And she was going all around because she was wearing an artificial limb. And her pain, pelvic pain, was being attributed to her artificial limb because it was from the hip downwards. And then when we did the scan, we saw the endometrioma and then the hemivagina with the renal agenesis, for which we operated on her. And right now she is in medical school.
So Mullerian, you both mean to say that Mullerian agenesis is also associated with endometriosis.
Yes.
Hello.
We too had a case of...
Asha? Yeah.
Yeah.
Hello.
We had a similar case like Ramani. She came at the age of 16 years with severe pain. And she had a transverse septum covering one of the cervices. She had 2 cervices and bicornuate uterus and a huge hematosalpinx. And this was way back, almost, I would say, about 1994, early days of laparoscopy. And this lady, we cleared that transverse septum covering 1 cervix. And those days, we did a laparoscopy. We did a linear salpingotomy and drained that hematosalpinx. Because 1994, that is the knowledge that we had. And later, that girl got married at the age of about 21, 22. She conceived beautifully without any problem. But she had a central placenta previa.
Oh, my God.
And she had a cesarean section, did well. And after 5 years, again, she came back saying that I have this pain, that pain, pelvic pain. So we did a second look laparoscopy, but she had no endometriosis anywhere, no adhesions. And after that laparoscopy, she had a second child also. She did very well.
Ragini?
Yeah.
Dr. Ragini? Yeah.
Yeah, I have joined.
Yes.
After long problem.
Yeah. So what was the youngest, what at youngest age that you have seen endometriosis?
Come again?
Youngest patient of endometriosis that you have seen?
So my youngest patient is a 18-year-old, and as I'm seeing what you have written here, 20-year-old girls comes with a severe pain. I really wonder why that patient is not taken for a USG and only put on the OCP, because as everybody is talking, Ochvira syndrome is quite not such an uncommon thing in the patient, and many a time they come with us, and I totally agree with Asha that after this endoscopy, the things has absolutely changed. And even my few patients, young patients, say 21, 22, if they are sexually active, I like to put the Marina instead of putting on them OCP in cases of this endometriosis.
So moral of the story is that if someone comes at young age with pain, dysmenorrhea, then it's very, very important to do ultrasound, and not to ignore and not to say that dysmenorrhea is common and it will go just after the marriage. So that sensitivity is very important. And this patient, unfortunately, again, I don't have the images, but she had bilateral kissing ovaries posterior to uterus, right ovary 4 to 5 centimeters chocolate cyst, left ovary again 4.5 centimeter chocolate cyst with pelvic adhesions. And we counseled her for medical management. So what sort of medical management would you be advising, Dr. Bharti? Dr. Bharti?
Yeah, Dr. Asha. Well, in today's scenario, I would go for Dynagist first. And of course, with proper counseling, and as Dr. Archana said, if they have, Dr. Ragini said, sorry, that if they are sexually active and we do the proper counseling, the Mirena would be the second option.
So, anyone else wants to give something else?
Dr. Asha, I would like to say, not all patients with bilateral chocolate cyst, they do respond to Dynagist.
Absolutely.
Only pain factor can reduce, but the size of the lesion will not go down. If she is happy with the reduction in the pain, that's okay. Agree. Let her go ahead with Dynagist. That is fine till she gets married, until she wants a baby. Otherwise, if she has crossed the age of 16 years, I don't mind using GnRH analogs because GnRH analogs definitely reduce the size of these endometriomas. That is one thing. So once when it reduces the size of the endometrioma, it prevents rupture of endometriosis. Rupture of endometrioma, though it is not uncommonly seen, we have to think about such things when the patient gets aggravation of pain upon the routine. So my choice will be try with Dydrofem. If she is better, continue on that till she plans to get a baby. Otherwise, if it is not responding, then maybe GnRH followed by Dydrofem. And of course, LNGIUS in sexually active girls or associated adenomyosis is there. I will go for LNGIUS. But surgery, I will definitely reserve unless the patient has failure to any one of these modalities of medical management. Otherwise, no role for surgery currently, except in failure of medical management.
Dr. Dasma Patra.
Dr. Ramani, I would just like to add one thing here. I think if everything is tried, as you are also saying, that surgery means we cannot rule out the option of surgery even in young women. Because if they are suffering and their quality of life, like today only I had one young girl, she had tried everything. She is appearing for IIT JEE. Her mother is saying that she has the similar size ovarian cyst. Do something, doctor. So
that is the last resort. I think I will also go for a surgery.
And especially if they are not responding after surgery, again they need to put on either on the Marina or on the Dydrofem.
And you should also counsel them regarding fertility preservation.
Yes.
Very important. She's an IT girl. She knows. I mean, she's able to read and understand. The family would be more concerned. So as you keep suppressing the girl, tell them that suddenly there can be resurgence of the disease. At which time it will go out of control, we never know. Initially, it may respond well.
So ultimately, she opted for surgery. And Dr. Dasma Patra, I want to know what should be the aim of the surgery and what sort of precautions would you be taking?
Before that, also can I make some comments?
Please.
Let me contradict Ramani Devi, who wanted to put her on GnRH analog. GnRH analog definitely detects the growth of the bones because it affects the calcium and the growth of the bone ends. So GnRH analog is contraindicated in young patients.
So that is what I was telling you. Patient girl beyond 16 years, we are justified in using
this girl was 20 years
for a short time.
20 years.
18 years.
Maybe beyond 18 years.
Yeah, probably if we are.
I am pleased that nobody prescribed her oral contraceptive.
No.
Nowadays, no.
For the last 5 years, that oral contraceptive actually makes the situation worse. It can
somebody has
hide the symptoms of the endometriosis, but inside, when you give oral contraceptive, especially containing estrogen, it will make
going to aggravate
the disease, although there will be no symptoms. That means we can similarly compare with the popular saying, the still water runs deep. Patient does not have symptoms, patient has symptomatic relief, but we are continuing the oral contraceptive. I am pleased that everybody has come up using oral contraceptives. Now, regarding the surgery, aim of the surgery will be to respect the healthy ovarian tissue. And everybody said that it affects the AMH level. But one should know that AMH level is very controversial measurement of the function of the ovaries. It is better to go for antral follicular studies. Now, AMH has been found to be low in presence of endometrioma, but there is also evidence that it can improve after removing the endometrioma. The low AMH, 1/3 of the patient improves the AMH concentration after endometrioma removal. So when you remove the endometrium, as you are doing in the picture, you should always respect the healthy ovarian tissue. You just try to dissect out the endometrial tissue, the cyst wall, and near the hilum, where usually the bleeding occurs. So you can cut the hilum little proximal to its origin, and then you can desiccate the hilum so that the bleeding does not happen. what happens when there is bleeding from the wall? We have the habit of desiccating the tissue again and again. And that destroys the healthy ovarian tissue. And the other question of keeping the fertility in the store, like ovarian tissue preservation, I think that is still not very efficient method, and it has become expensive. I try to do in some cases because the patient has gone through the website. They wanted me to preserve their ovarian tissue, but I could not get any help from the IVF specialist. They said, Dada, we have not started yet. So that is not available. I think what you know that embryo fusion is very important. That is effective. Whether the freezing the ovary for future fertility is still controversial.
Correct. Egg freezing is easily available, and we are freezing the eggs very often nowadays. Every month, I think I have one patient coming up for egg freezing, and vitrification really gives us very good results. So I think egg freezing is a very good idea in such cases.
Egg freezing definitely, but not for ovarian tissue.
Dr. Asha, I would like to add up one more point. Now we have the availability of elagolix, which is available. If you think that its analog is going, this Leupride-Depot or whatever is going to cause reduction in bone mineral density, the elagolix, which is given at a moderate dose of 150 milligram per day, that is definitely going to, that will not reduce the BMD. Okay, but it has got the initial flare effect.
What is the cost of elagolix? Any idea?
Elagolix in India, I do not know. India, I think it is not available, but I was chatting with the Bangladeshi friends. There
but it's not available in India. I think that will be very expensive also.
Probably
they are making it available.
Yeah, probably we'll get it soon. And they said in Dhaka, that is in Bangladeshi rupees, it is 60 rupees each tablet.
Not bad.
That's what I was really surprised to hear that. So they are all using quite a good amount of elagolix in Bangladesh. Sir, from Mahapatra sir, you will be knowing because you are very close to them.
May I remind you something?
Madam, it says on India Mart, elagolix is available.
Comparing the efficacy of
56 tablets at 5,000 rupees. So that comes to almost the same price, around 100 rupees a tablet.
Which company?
It says, let me open and see.
Sorry?
Orilissa. The drug name is Orilissa, and it's elagolix from brand Orilissa, it says.
Okay.
No, Alchem is bringing now. Alchem is.
So far, it is not available, Dr. Bharat.
Yeah, no medical company
it is not available, but they are making efforts. In another 6 months, it will be available.
Very good. Excellent.
Let me tell you this. This is a publication made by one of the researchers in the States who claimed that the elagolix or antagonist not superior to any other drugs when they compared with the Depo-Provera. They found the efficacy is exactly same as the Depo-Provera. So why do you spend so much of money, which is not very we still do not know. And moreover, it is not available, freely available in India. Importing medicines from Bangladesh, you can end up buying some spurious medicines. That you used to be very careful. If it is 50 to 50 taka for one tablet, that means it must be a spurious drug.
I think about the long-term prevention, I think already you have spoken. We can think about Mirena or any suggestions about it? Long-term protection, because she's a young girl, so she will need protection for the long term. Otherwise, endometriosis is going to come again with the vengeance. So,
if you take my opinion, I'll put her on simply Depo-Provera injection or the tablet.
Sir, again, Depo-Provera can cause reduction in BMD.
BMD and those cysts also.
Most of the girls today are sexually active. I think the Mirena is the best answer.
3% of the patient with long-term.
If they do not accept Mirena, you can give them Dynogest for about 5 to 6 years.
Yes.
Yeah.
At least 3.
Anybody comment that long-term use of Dynogest can cause a breast cancer?
No.
No,
not at all.
No.
Not
maximum 3 years.
The WIPO study has The bypass study by Bayer, they have studied it for about 7 years, 84-month study.
But the one point you have to remember that with Danogest, younger patients are likely to get complain of headache after 6 months. And I remember one patient, headache.
It's about 5% of them, according to the statistics.
According to the statistics, which statistics? I am saying young patients.
Yes, okay, sir. Young patient 5%.
No.
Yeah.
Maybe the overall 5% is what the company says. But if you keep your records, you check your records and you will find it is more than 5% in younger patients.
Okay. So today we have learned from all our experts various views, and we have learned lots of new things also. And it has been a very satisfying panel, and I would like to thank you all. At the end, I would like to say that in the era of high deficiency ultrasound, MRI, endometriosis, which Dr. Kuldeep said, these days we should not come across surprises. We should be able to diagnose the endometriosis and map it so that we can plan the treatment accordingly and follow it up. And the proper counseling is very important. Discuss the recurrence and complications of the procedure. First, surgery should be the best surgery. So it should be done at a center that is expert in doing this type of surgery, because deep infiltrating endometriosis surgery is the very tricky surgery. So it has to be done by a person who has avid interest in surgery. It may take hours together, and that person should be dedicated for endometriosis. Then we have to discuss about the oocyte and embryo freezing option, and surgery these days prior to every ART is not necessary. So you can proceed to ART without going for laparoscopy for every patient. So I would like to thank you all, and it has been a very enriching experience.
Can I be allowed to share my screen?
Yes.
Asha, it was a wonderful panel and we enjoyed, Asha and Archana.
Correct.
Yes. I must say that I have learned many things. Endometriosis is such a enigmatic disease to learn, and every time I learn the new things. Thank you, and 3 Bs.
And the best part is every panelist is like our next door friends.
Yes. So thank you, 3 Bs.
Welcome Kavita to Coimbatore at the weekend.
Thank you to all the 3 Bs. Excellent
Asha and Archana, and always the endometriosis queens. I must say Asha and Ramani.
Yeah.
Always have to be there with Asha Rao and Ramani.
But the Mahapatra sir was the best.
Mahapatra sir is expert.
Sorry to say so.
Mahapatra sir is the king of
endometriosis. That's what I was telling.
We love listening.
I'm operating at my place with a girl with endometriosis. He is wonderful in operating endometriosis.
Oh.
That's a low resource thing, you don't have endo bag, so make a bag with the gloves and all. So
nice.
Amazing, sir.
And everyone had different opinions. So that was the best thing about it.
All of you to be a member of
Endometriosis Society of India.
Yes, sir.
I must.
I know Ramani.
I am member of Endometriosis Society, sir. I am member. Ramani made.
Me and Dr. Bakshi will become soon.
What is a member?
Yes.
Me too.
Definitely.
Bharti, we will become.
Yes, sure. Yeah, we will become immediately tomorrow morning.
Today only.
Because
okay, fine.
In fact, what happened in Indore conference in 2003, we are coming back from Indore to Calcutta. And the flight was delayed by 2 hours. And I was sitting there, and Dr. Vivian Chakraborty was sitting on the other side. So, how difficult it is to spend time with a teacher.
I can imagine.
I thought that I should talk something academic, because he's such a great academic here. So I approached him, said, do you think we should open up an endometriosis society? He said, why not? Why not? And that's how the concept of endometriosis society was at Indore Stadium.
Correct. Indore Airport.
The flight was delayed for a reason.
Maybe. Okay, thank you very much.
Thank you.
Thank you very much.
I would like to ask on Kalyani to just propose a vote of thanks.
And to Emcure people as well.
Thanks a lot, ma'am. Thanks a lot.
Thank you. Thank you so much, everyone, for joining in today. And it was a master blaster session. Yani we learned everything right from the hypertensive, the dialogue, from the imaging to the common queries that we all have in a day-to-day practice. And trust me, all the ma'ams and sir here, I have learned so much today. Like I'm practicing infertility, but I guess there's so much to learn in endometriosis. I was all puzzled with question marks that there is so much. And yesterday I had the opportunity to listen to Asha Rao ma'am. So adenomyosis plus endometriosis, I think I have covered. And this is one subject which from my residency till now I fear the most, because every patient comes with a different scenario. So, not everything fits for one patient, or nothing, or all the guidelines fits for one patient. It's so different for everyone. So I think sharing all your experiences, what you all have shared with us, is an enlightening thing for us to guide our patients in a better way. Like Bakshi ma'am said, first surgery has to be the best. Whatever we are guiding the patient right from the adolescent till year, it has to be the best. So take home messages that make a plan for any person who is coming to you and give them the proper guidance. If we cannot deliver the treatment, we should be able to guide our patient to go to the best of the doctor to take that treatment. Right now, I think you agree with me that this is what we have to learn, how to tackle each and every patient right from every age group till the infertility, till they deliver and till they go back home. So thank you, everyone. It has been a pleasure for me to host this session today. Thank you, Emcure. Thank you, Baser ma'am, Bakshi ma'am, and Bapat ma'am for giving me this opportunity. And thank you all esteemed faculties. Namaste. And I adore you all. And thank you so much from all my heart for being here with us.
Thank you, Kalyani, for really hosting it so well and organizing it so beautifully. And thank you, Emcure, for giving us the platform.
Thank
you, Mama. Thanks a lot, ma'am.
Thanks, everyone.
Bye.
Thank you, Kalyani. Excellent job.
Bye, ma'am. One second. Please hold on. Please, everyone, please smile. I can take a picture.
We have not taken a picture, no?
Yes, ma'am. Please smile. Thank you.
Thank you.
Thank you, ma'am.
Thank you all. Have a nice evening.
Bye. Happy weekend.
Bye, Bharti.
Bye, Asha.
Bye.
Ramani madam, good night. Ramani madam is gone.